Hello, this is Vijay Batuman. I'm the interim chair of the Deming Department of Medicine, and I'd like to welcome you all to today's Grand Rounds. Our speaker today, Dr. Kevin Krane, is well known to the Tulane community. He's a professor of medicine and the vice dean for academic affairs. Dr. Krane is a graduate of Michigan State University with high honors and received his MD from Tulane University School of Medicine. He completed his residency and chief residency in internal medicine and fellowship in nephrology and hypertension at Henry Ford Hospital before joining Tulane faculty some time ago. He has also served as Harvard Macy Fellow in Medical Education Reform. He has widely published in medical education and has been an invited presenter at numerous educational meetings. A nationally recognized medical educator, he has served as the chair of the AAMC's Southern Group on Educational Affairs. He has also served as a site host for the 8th annual meeting of the International Association of Medical Science Educators and their regional meeting in New Orleans in April 2009. Dr. Krane has received many teaching awards at every level, including the Tulane University Medical Center Teaching Scholar Award and the Tulane University President's Award for Excellence in Teaching. Dr. Krane is a Team STEPS master trainer and is directly involved in the training of healthcare personnel and the national implementation of Team STEPS, which is an evidence-based teamwork system aimed at optimizing patient outcomes, improving communication, and other teamwork skills among healthcare professionals. His academic interests are renal disease in pregnancy, peritoneal dialysis, and enhancements of medical student education. During this pandemic, Dr. Krane and his colleagues have been working tirelessly to create solutions to continue Tulane's tradition of excellence in medical education while safeguarding safety. And he will tell us some of the things that they have been doing today. Thank you for joining us today, Dr. Krane.
Great, thank you. I'll get us started. And I'd first like to say that one of the most important things that Dr. Bottoman said was that the efforts that we have made here at Tulane over the last 3 to 4 months have really been a team effort, both from the medical educators and the Office of Medical Education, the clerkship directors, the course directors, and the support staff. So there's a large set of people who have been working pretty tirelessly on all this. So I'm going to talk about the medical student education in the COVID era, which, as we all know, is really just started a few months ago. And I'm going to talk a little bit about where we've been, where we are, and what does the future hold, not just here at Tulane, but just in general when we look at things. So if you look back to March, and I will add a personal note, I actually was doing a presentation at the International Association of Medical Science Educators on March 1st in Malaysia, of all places, where they really had very few cases at the time. And it was right about that time that everything exploded in the United States. So I came back, and immediately by March 5th, the AAMC had already jumped in to raise some important education and safety considerations for medical students. First of all, looking at non-clinical courses, that we were not obligated to bring people in person if we didn't think it was safe based on local public health. In the introduction to clinical medicine courses, where students do get clinical exposure, particularly in years 1 and 2, they suggested considering suspending those activities as early as March 5th. And then for students on clinical rotations, at this point, they suggested that students continue their activities as part of the care team. So what actually happened in New Orleans? And let's look at it from that perspective. So on March 9th, we had our first case of COVID-19. It was reported by someone who lived outside of Orleans Parish, but was hospitalized at the VA hospital. And this really gives you the large graphics. So if you look at the bottom, you can see March 9th, our first case. And we peaked very quickly, as everyone who lives here knows, pretty dramatic. As early as March 16th, the mayor made a proclamation. We immediately lost our St. Patrick's Day parades. all the parades and everything we normally do, and all of a sudden disappeared. And fortunately, that was obviously in retrospect the right decision. The governor's stay-at-home order by March 22nd, and you can see what happened over 2 weeks, pretty remarkable rise. So the clinical milieu in which we were living was rapidly, rapidly changing. So let's look at what happened with the students. And here's where things stood on that day on March 9th. So on March 9th, the fourth-year students who were looking forward to their graduation, most of them had done all their required activities. So they'd done all of their required clerkships, and each clerkship has a set of required encounters that are necessary for each experience. There were still a number of students, though, who had not finished their emergency medicine or community health or radiology. The third-year students had just begun their final clerkship of the year. The second-year students, fortunately for us, had really just finished their coursework and were preparing for their USMLE Step 1 licensing exam. And the first-year students were finishing up their initial phase of their curriculum, which is really their phase 1 or normal structure function. And we're just about to transition through exams to begin their abnormal structure function, which we call phase 2. So the events occurred very rapidly. As I mentioned, March 9th, the first case of COVID appeared, reported in New Orleans, and we immediately began to look at what was going on, and new policies were immediately implemented. At this point, we realized that there were concerns about PPE, and so policies came out for our students that they were not allowed to see COVID patients or even those who were under investigation. One student per case was allowed in the operating room. And we looked real carefully at all of the required clinical encounters and in terms of what was necessary. By March 13th, all exams were moved to distance online software, most of it using online proctoring software, many of which we didn't even know existed at the time, but we've since become very familiar with. If we look at what happened very quickly, by March 16th, we immediately pulled all of the third and fourth year students from clinical duties. This was right when things were beginning to rise very quickly, and we all realized we had a very significant problem in the city of New Orleans, in the immediate area. This obviously coincided with the mayor's stay-at-home proclamation, but we immediately announced that all students on all clinical duties, meaning the third and fourth year students, were suspended from their activities, regardless of which hospital, which clinic, and they were immediately put back through the stay-at-home proclamation. So a number of immediate issues occurred right at this time. You can imagine a lot of confusion. We now had no students on the main campus or on the downtown campus, our main campus. And so a number of immediate issues occurred. And let me just give you a picture from the students. So imagine being a fourth year student and wondering, can I graduate and will I be able to graduate? For many of us, one of the big questions that came up early on was the issue, and some schools did do this, was the discussion of should students graduate early. And I just wanted to let you know, we had a lot of discussion about that at the administrative levels, but it became very clear early on that the licensing and onboarding issues associated with it are very significant. And if they're not all lined up, we could actually graduate students early who really had no place to go, couldn't get paid if they did move on. So we decided not to do that, and we'll talk a little bit about how we made sure that students could graduate and how that fit real quickly with our licensing and with our accreditation agencies. And one of the things that did occur was the LCME immediately made some changes. The LCME, of course, is the organization that accredits medical schools in the United States and Canada, but they immediately redefined the requirements to make it very clear that these required clinical activities that I referred to earlier are really the most important thing that we do. So if a student has elective activities that still needed to be done, those were truly elective, and if a student had finished all their required activities, elective activities could be suspended and a student could move forward and graduate. So while the fourth year students may not have completed the prerequisite courses which included electives, we were able to make changes to our curriculum committee to reduce the number of required electives. And as a result, these students were easily able to graduate and meet all the standards expected of our accreditation agency. The third year students were now disengaged from their clinical activities and trying to redefine what the didactics were for their clerkships. The second year students were out at this time, and their big issue was, how do I take the USMLE Step 1 exam as the centers around the country started closing, and even when students had appointments to take the exam, which are done typically at a prometric exam center, they were not able to do so because all of these centers were closed due to, especially in places obviously like New York, but they were closing all over the country. And finally, the first year students were reduced to distance learning with no on-campus activities. And for all the students, regardless of level, all their exams now became remote online exams. So by March 18th, all the classes were placed on Zoom video conferences until further notice. This included classes that were for first year students who were still finishing the year, or even the didactic activities for third year students and for some fourth year students. We made the final exams optional for first year students because of the challenges of administering the exam initially, if they had no academic deficiencies. Remember that year one is a pass-fail, and for many of the students, they had done very well. We provided the exam for them, but we did not require them to take it with a passing grade to move forward. The clinical students continued their didactic activities and did something which had not been done previously, which was they were unable to continue clinical activities. So whether they're on surgery or psychiatry or medicine, they continued the didactic portion of the clerkship and actually completed the standard shelf exams before they completed the clinical activities. As you can imagine, there were major disruptions I alluded to earlier with the students' ability to take the USMLE exam. So there were most of the second year students who were taking step 1 couldn't do that, and this was a national phenomena, and it really created dramatic disruption around the country. USMLE step 2, typically taken by students early in their fourth year or at the very end of third year, was also disrupted. And the clinical skills exam administered by USMLE was completely suspended, and in fact remains suspended to this date. They've not been able to restate it, much to the delight of students who otherwise would have been required to take it. There also was the importance of recognizing that these required clinical activities for each clerkship are particularly important, and they help define what students do. And in fact, for students who required emergency medicine to graduate, if they completed an activity that was a required clinical activity for emergency medicine but had done it during another clerkship, the LCME considered that an acceptable way of meeting that standard. For example, if emergency medicine, which it does, requires students to participate, be involved in a major trauma activity, if students experience that same activity on surgery, then they were given credit for it, even if they'd done it on a different clerkship. So there's a recognition that clinical activities run across a spectrum and throughout the year, and they really are not always defined, but the individual's clerkship, as these activities are part of what we do for graduation. So here's how we managed everything after March 18th, bringing us more to the present time. So in March 18th, if you look at the activities for third and fourth year students, it's remarkable what our students did. A significant number of them organized and volunteered, spending incredible amounts of time, and they essentially mounted a campaign to obtain remarkable amounts of PPE that other administrative units were not able to do. Remarkable job by our students. They also participated in a variety of indirect patient care activities, which were truly educational for them. They were including volunteer activities, MPH work, research, and a lot of students did non-clinical activities for credit that they were able to do through other courses. On March 16th, the fourth year students from the previous year were able to graduate with a virtual graduation, typical of what went on around the country. And during the month of May, we also offered some brand new synchronous online electives that were created specifically for this period, including a specific month on COVID-19 with activities related to public health and leadership. The pediatric department created an allergy, immunology, rheumatology experience. And we also were able to tap into the University of Oregon's bioinformatics online course. And we do offer some online electives. So a number of students were able to get some credits towards their graduation while doing meaningful educational activities. In May, the first year students were able to take their final exam. And in June, those students who had been disrupted were able to return, which were the rising current fourth-year students, to finish any of the required clinical activities that they were not able to do during clerkships in March and April. In July, we returned to what seemed to be a much more normal approach. The third-year students started their clerkships. However, all the 8-week experiences, medicine, surgery, pediatrics, OB-GYN, were reduced to 6 weeks. And the 4 weeks of neurology and psychiatry were reduced to 3. And so the third year for our students typically starts in May of each year. We started in July, but they'll finish essentially at about the same time. And we're hoping that we'll get everybody back on track to the sort of normal curriculum year that we're used to. So let's start looking forward. So that sort of gives everybody and brings everybody up to speed as to where have we been and where are we going. So in the COVID era, things have changed drastically. I don't need to tell anybody our lives are really very different. And fortunately, I think we've begun to accept some of these changes, though we realize we'll be with this for a while. But really the first goal is of our students, our faculty and staff, obviously our patients too, but in terms of the educational program is making sure that everybody stays safe. Well, for medical students, we really have a set of assumptions that are particularly important. First of all, anybody who participates in true medical education is involved in the care of patients, which is necessary to obtain a degree. So we're not talking about eliminating risk. The only way to eliminate risk, obviously, is to stay home and to completely isolate. However, if we're going to bring students back to campus for clinical activities and for other educational activities that we think need to be in person, our goal is to make sure that the risk is truly minimal and that everybody feels comfortable. Second of all, for our purposes, we've defined medical students as non-essential healthcare personnel. Occasionally, institutions may change that. There are few institutions that did ask medical students to volunteer to participate in the care of patients with COVID because they truly needed additional healthcare personnel. This occurred up in New York. But really in very few places. So medical students are not essential, so it's particularly important that we protect them. And that we also need to be absolutely sure that the faculty, the residents and staff, and the environment in which they work models and practices those safe behaviors. We all know all too well that students are going to follow the lead of their faculty and their residents, and so the behaviors that they model are the behaviors that students are likely to follow. So it's very important that everybody get on board and model the best behaviors. We also have to accept that students can't meet all of their competencies for graduation and for residency training unless they have direct clinical encounters. So as I mentioned earlier, the medical degree is going to be one in which we bring students back. We do put them at a risk, but the risk needs to be minimal, and it has to be with direct clinical encounters. And finally, the whole approach to our care has to be teamwork oriented with essential skills and behaviors, all part of medical training. These are all things we try and instill and train the students beginning in year one, which means that at the end of the day, the MD is not an online degree, and it's impossible to be able to grant the MD without that. And meeting the LCME and accreditation standards, they would completely agree that there are required clinical activities and different types of training that students must participate in to obtain the degree. And it's really our job to determine how we can do that in the safest setting and make sure everybody feels comfortable. So let's look at things from a pre-clerkship standpoint and talk about what can be done. And by pre-clerkship, I'm referring to the traditional years one and two. There are a variety of variations in medical schools. But let's focus and think of the period of time before students are fully immersed in their clerkships, which again, as I said, at our school, students start their clerkships in May of their second year, though this period of time is becoming shorter and shorter in other medical schools as well. So the most important thing that I can ask people to do is think differently. So in the COVID era, we can't do what we used to do. Almost everything we do is done differently, whether it's going to the grocery store, whether it's If you go to a restaurant, do you choose to go to a restaurant first of all? Do you go to a restaurant if you can only seat outside? And so there are a lot of variations, and certainly in New Orleans, our loss of essentially complete loss of live music, everything is different. So we have to think different to be sure that we're preparing and providing the best education. So let's go through a couple items. So let's start with anatomy. I mean, let's face it, traditional anatomy is done with cadavers and cadaver dissection. Typically at Tulane, and for the last at least 50 years, without exaggeration, students come in, they're divided into teams of 6, they crowd around a cadaver, and they do a lot of dissection over a period of time in the fall of their first year. We can't do that. So what can we do? Well, first of all, many medical schools are going to completely virtual anatomy. The software and the digital educational materials that are available are very sophisticated, and many programs feel that that is adequate for what they're doing, and it's really the safest thing to do. So many schools are providing fully online cadaver or lack of cadaver anatomy, but fully online anatomy courses. We're taking a slightly different approach. A lot of the anatomy that students will learn this year will be virtual, but they will have some exposure to prosected cadavers, which is typically not what we do, and only 2 students at a time, both of them wearing full PPE, will be allowed to come in and view a prosected cadaver as part of their experience. There's a lot of discussion about the importance of cadavers. One could certainly argue that cadavers are not at all necessary. On the other hand, one could argue that the ability to work with the human body provides also a type of psychosocial engagement that's important for professional identity formation for physicians. Be that as it may, our course will be very different. Typically, it's a course that's administered through the fall, but instead this year, the course will be given longitudinally over an extended period of time with prosected cadavers. Many of our courses are given as large group. We have 190 students. I was recently asked about something in the AAMC, and as I said, which is quoted here, is that we can't just move everything online, and the students really would die of boredom, just like we do sitting in front of Zoom conferencing all day if all they did was sit home and watch lectures. So medical education is not about that, and we have to think differently, and this is a great time to step back and ask ourselves, what are we doing? So let's look a little bit about that. So look at class time. So class time in many institutions has become much more. We've moved in that direction. I believe personally we can do a lot more. It's really about applying knowledge in class, not dispensing it. So one of the key areas is getting students to prepare for the classroom activity. And while many people go, students never prepare anything, well, that's because we don't make it an expectation and we don't arrange our educational program in a way that it's valuable for them to do that. And the more we do that, which we are beginning to do, the more students will come prepared, and they'll come prepared to apply information. So to do that, one, from an educational perspective, must provide very clear objectives for a learning session. One has to provide really good learning resources from which to prepare and learn about those objectives. And then you really have to have a game plan for what you do in class, whether it's case-based learning, team-based learning, peer discussions, or whatever. I've shown here some examples of learning resources. They can be short pre-recorded lectures. There are many that are available. You can make your own, which actually is more difficult than it seems. There are remarkably good commercial products. I hate to say it, but they're really good. Now, here's some examples from Sketchy Micro, Pathoma, and so forth. And if you go to YouTube, you name the topic, it's out there. I took as an example valvular heart disease. So you can go to Khan Academy. There are a whole series of videos that are available that one can watch on YouTube that provide students with brief and very accurate information from which you can use. You can give them articles or chapters. But again, think of large group activities as an opportunity to engage students in a discussion, not give them the facts. So the real question is, can you go online and be interactive? Well, here's a quote that just came out literally today from a friend and colleague, Dean Parmalee, who was the academic dean at Wright State for many years, still working there in a variety of activities. And as he points out at Wright State, we've had no lectures and again, I'm going to say that one more time, we have had no lectures, pre-recorded or otherwise, for over 3 years. All classroom instruction has been, and he describes the different methods. So this does occur, this is occurring, it can be done, and this is where modern education is going. And this may be a great opportunity for us all to step back and think about what we're doing in the classroom. What about just basic Zoom sessions? So imagine doing even your Zoom sessions. I actually wanted to try and do the breakout rooms, which are difficult to do in this sort of format, but it's incredibly easy to take as many students as you have and put them in little rooms. So if you're doing Zoom sessions, look at the breakout room tab, figure out how many people, figure out how many people per session, go click, and the next thing you know, they're all in little small groups having a discussion. It's a wonderful way to engage students, very simple. Again, I urge everybody to think about that, and there are a lot of people in the Department of Medicine who teach throughout years 1 and 2. Other approaches are to use audience response or quizzes or others. You can use Turning Point, which I've also used in classrooms. You can use the session. There's a way of doing questions through Zoom. So a variety of different approaches, and the support for doing that is there. As you can see in the question, if you had to run a course, the right answer is to get support from the Office of Medical Education. They can easily show you and set you up on how to do things. And of course, even the sessions are now done through distance learning. So other things that we have to think about differently. What about in-class activities for our first and second year students? Well, again, it's very important that students learn specific behaviors, skills, attitudes, and teamwork to participate and function effectively as a physician. So to do that, there are a variety of small group sessions that are required. We are continuing our standardized patient program. We've reassured the students that the SPs are tested. We provide PPE for everybody. We are not doing oral exams. So we're doing those things to keep people as safe as possible. The same with the simulation center activities. And there are a variety of clinical encounters because students in years 1 to 2 do need to learn how to take history and physical exams with real patients. And we continue to have a lot of the community clinics that our students volunteer at with, again, safety measures built in that have been approved through a number of different protocols and personnel. Team events can occur in person. We have learning communities, case-based learning, team-based learning. And our rule, though, is that all of these have to be limited to no more than 10 people in any setting. And as long as we have facilities that can accommodate that, we're doing that. So we have required our students to return for first and second year so that we can have them participate in small group sessions, the in-class activities, so we can work with them in these types of activities. So a number of other activities and other issues are particularly important. The whole issue of testing is another challenge. We have tested all our incoming first and second year students, of whom only one tested positive out of all of them. It turns out that the one who tested positive was actually from his mother with whom he was living. So one of our goals is to get students to understand how important it is to keep themselves safe, knowing that they already are negative. And many institutions, including Tulane University, are struggling with the issue of how often do you retest. Big debate going on everywhere. I don't have the answer, but we are following the institutional protocols. All the exams are remote. Most of them are proctored. Some of them are honored system, a change that we've had to go to. And we need to look at real carefully at the resources that we have to support all that. So faculty development is very important. I already mentioned that if anybody needs support in how to do things through online sessions, they should work with the Office of Medical Education, trying to get people to use the different systems, understand how they work, is very, very important during this setting, and will really enhance your ability to deliver high quality educational programs rather than getting on a Zoom session and going on for an hour, which is not what students want, and I don't think what people should be doing. There are lots of educational materials that are available for online education we can provide, but more may be necessary in terms of resources. The physical space becomes an issue. I mentioned groups no larger than 10, so we both need classrooms as well as student study and support space. The library has just opened. PP is a big issue, obviously, in terms of any clinical encounters or even encounters with standardized patients. Fortunately, at we do have enough PB for these types of activities. And obviously technology and IT support is paramount in this era. So I urge everyone to think about what they're doing, their traditional approaches, and looking at how we can do medical education different. So let's turn to clinical education. I'm going to see if we can do something a little different. So let me ask a question and ask people to put just a response in the Q&A box. Does anything need to be done differently for clinical education in the hospital setting or even in the clinic setting? And if so, what? So I'm going to give you about 60 seconds to think about, is there something that we should be doing? Put it in the Q&A box and we will come back to it. Now, the good news is this is totally anonymous. It's a great opportunity. Okay, I'm waiting for one more person to respond. Okay, so I'm going to read out the couple of the responses I received. One is make sure that students are wearing proper PPE and are not seeing COVID patients. Another one is minimizing the number of team members who go into each room. However, that could result in a medical student being out. And making sure that everyone is clear on a PPE protocol and figuring out ways to enforce and follow up on it. Okay, so let me move forward. I'm going to come back to my screen. Okay. So let's look at what's going on. So here's an example. I took some pictures last week on rounds with permission, I can assure you. And let's
Kevin, we don't see your screen.
Okay, thank you very much. Let me reshare. Okay, I'm assuming that looks a little bit better. And my little sign says I am screen sharing. So again, I just took, and I can assure you these were done randomly, and they were taken only because people were available and were kind enough to allow me to take permission, get permission and take pictures, and obviously you will not see any patients at all. So again, this question of how many people should be rounding together. We can talk about social distancing, but in clinical medicine, in general, if you're seeing patients, it's pretty hard to see a patient from 6 feet away. So the whole issue of social distancing breaks down. But what about on rounds? I mean, should we be this close together on rounds? Here's a team of 1, 2, 3, 4, 5, 6, 7, 8 people outside an ICU room. They're all obviously less than 6 feet apart. Everybody's wearing their masks. One person's wearing a face shield. So again, it raises questions of, is there something we can do? And the size of the teams does become an issue. I can assure you that I've spoken to colleagues from other academic centers around the country, and this is a universal issue. So hardly unique to Tulane or to our institution. The size of teams at academic centers is large, and how do you protect everyone? So I'm going to move forward, and I'm going to skip my question here. Here is a typical medicine team. And I say typical in terms of the number of participants. There's an attending. Everybody's out in the hallway. You can see it's not quite as large as the other team. Everybody is wearing a mask, and there is a little bit of spacing between people. But again, this was taken last week, so this is essentially real-time snapshots of what's occurring in our institution. So this gives you a flavor of what's going on. We can talk about whether this is a reasonable amount of distancing, giving the space in the hallway, but at least you can see there's it's a smaller team. They're not as grouped together as the previous team. So I'm going to move forward a little bit. Okay. Here's another team, again, taken with permission. By coincidence, happened to be at the analysis unit. And you can see a grouping of people in the space, what appears to be the attending physician, the nurses there. And so I'm going to put up a question, and we'll do this one more time. So again, going back to the question and answer box, is there something that this team is doing well or something that they're not doing well? I'm going to go back one more. So again, if you can put in your question and answer box, is there something that this team, again, taken at random, because they were available at the time, that they're doing well, or is there something that if you came by, you would recommend they do differently in the current COVID era? So again, I'm going to give everybody about a minute and see what sort of responses we get. So I'm going to assume if nobody answers that they thought that this last team was doing everything perfectly. Okay, so I'm going to go back. And I'm assuming that you can see my screen again. I'm going back and forth. And the most common comment I received from people was crowded. And obviously this is a pretty close crowding. And as you can imagine, if you look off to the right, there's a patient over here. There's actually, you can't see, but the patient is behind here. So everybody really is very crowded into a small space. And again, we tend to get used to doing rounds the same way, but can you really do things the same way in the COVID era? Do we really need to be thinking differently about how we do things? So I'm going to give you another example. Here's a workroom. And I already had one comment from someone about the issue of workroom and workroom space, about what's occurring. So you can see here, people at least are wearing their masks and they're spread out. But I'll tell you something about this picture in particular. Again, with permission, taken at random. When I first came by, one of the people in the room was not wearing a mask and sitting by their computer. And again, when I brought this up, they very politely thanked me and said, no problem, they put their mask on. But again, the issue of workrooms, as brought up, is a whole nother issue, and how we approach the spaces that we have for our healthcare workers, which includes not just the people in this room, but includes the medical students and occasionally others who are gathering together. So this is a real challenge, and again, is one echoed by colleagues that I've heard around the country of students, residents, and even faculty gathering in small areas and getting together. The good news in this picture is that they are all wearing masks. What I will say, the major concern many of us have is that students and residents, to use a colloquial, let their guard down and at times do take off their masks or come in here and snack and take off masks to have food. And probably the most dangerous period of time is when people are crowded together, they don't have their masks on, even for what seem to be legitimate or innocent reasons, they're putting everybody at risk. So again, these are concerns in the COVID era that we really have to look at. So again, we really have to think differently about how we deliver clinical care in this setting. So in terms of traditional rounds with the teams, the faculty and the residents must expect and model ideal behaviors. So it's not that people want to police people, but you have to model ideal behaviors. And the question is, what are ideal behaviors? If you look at what we require of our medical students, we do, and there is a policy that requires medical students to wear face shields in addition to masks for all of their healthcare encounters. And to do that, it's very important that residents and faculty do that. And in fact, I would say if it's required of the students, there's a reason, because it is part of the CDC guidelines for additional protection. For me personally, I wear a face shield because I want to be protected. So I think all of us need to be looking out for each other. So the safety of everyone has to be a top priority. When people come in the hospital, we know who's COVID positive, or at least who may be at risk. So we know the people who are likely to be at risk as patients, but what about our colleagues that we work with? And things are going to evolve very quickly as the school year returns, and many of the people we work with have children, and the children are going to school. How comfortable are we that we're all staying protected? Very, very important. So the whole issue of team size, distancing during rounds is very important, and trying to get people to think about this as we do that. So keeping some space during rounds, as difficult it is, trying to come up with teams that are not so enormous, very important. How many and who should enter a patient room? We saw an example of an army of people going into a small, relatively enclosed area with too many people. And I can promise you, if you go to the hospital, you'll see that happen. And it's not done obviously maliciously, because people are we're used to doing it the same way. So people need to think differently. Ideally, we'd like to reduce the learner to patient ratio, if at all possible. And some institutions are looking at ways to change communication on rounds to address a limited team size in the room. So using, for example, an iPad with the patient in the room, with only a couple of people entering the room, communicating to those outside of the room, whether they're at a distance down the hall or right outside the room, but again, limiting the number of people in the room. And the other big issue, which again, the whole issue of PPE, making sure people are wearing the right PPE and modeling the proper behavior. So much of this comes from guidelines and policies. CDC, obviously, the university has its own, the state and city, so we have to follow all those guidelines. There are also a set of guidelines for that specialties are providing for students as they go through their year. The AAMC, the LCME provide resources, but they also have resource sites with a lot of information. In fact, even today, there's a consensus guidance on face coverings that just came out from the AAMC. So this is rapidly evolving, latest information. They make it readily available. The specialty societies also provide information. So it's very important to stay on top of what the national guidelines and policies are to keep people safe. Here's an example of what you hope to see, a medicine team wearing all of the appropriate PPE. Very happy to do so, as you can see. And hopefully when the camera was turned off, they're wearing the exact same PPE, the face shields, and doing the same. But again, here's a team of 7 people and trying to keep some space. So making rounds is challenging, and I think all of us need to work very hard at thinking about how we do things on a day-to-day basis for the safety of our patients, but particularly for the safety of each other, because this may be the most dangerous period when we work together. So let's come back to some of the basic issues related to the clerkships. So very important that we have and we distribute COVID policies for the students that the faculty, the residents, and even the different hospitals and clinics follow, because we send students to a lot of different settings. Very, very important. The whole issue of COVID-19 testing, who, how often, way more than that's worth a whole hour's discussion, and we probably wouldn't reach a conclusion. Physical safety with masks, distancing, appropriate eyewear, PPE, N95 masks, and I'm not even talking about the challenges of doing procedures, the OR, and surgery, but those are real issues as well. What about healthcare personnel who are positive? Very important that the information gets identified. Is it identified just by the health department? If it's a student, does student affairs know about it? Who does the contact tracing? What about quarantine, residents and classmates, others who are involved? Very, very important. We even have roommate issues. So there's a lot going on, and probably the most important for people to be aware of is that there is a difference between a significant exposure and a minimal exposure. Significant exposure is going to be 14 days of quarantine for people, and minimal exposure may be no time off. So the minimal exposures occur when people wear their masks, wear their shields, keep their distance, even if they're around somebody who subsequently tests positive. So again, a lot of effort and time has to be put in terms of keeping us all safe, keeping the students safe, and being able to get through the clerkships. So let's look through some of the things that are a little bit different. Traditional activities, we mentioned the charting, the EMR, trying to create space, remote work. I will tell you, for those who do know, that I'm actually trying hard to see if there's a way we can get remote access to Meditech for medical students at Tulane, because it would create some distancing and remote work. I do have the support of our chief medical officer, but apparently this is an HCA policy, but it's certainly worth addressing as a safety issue. When you're doing conferencing in clinical settings, space and distancing, same issue. The traditional didactics have moved online, and there is a lot of sim center and standardized patient activity on the clerkships. Again, we follow a variety of procedures that we believe are safe for our students, but it's important that everybody stay on board with those as well. So let's look a little bit about where things have changed, and this, as I sort of move towards the end, what are the things that are the sacred cows that have moved out to pasture as we look at medicine and look at the COVID era as an opportunity to think differently. So one of the things that actually I don't think has ever changed is the day one of medical school, when many of us looked around at all these awesome people around and wondered, how did I get into medical school? These people are so much smarter and so much more accomplished. But that opportunity to meet people and recognize they're different. The difference is this year, it was very challenging for us to be able to get people to meet each other. So we did come up with a system for our brand new first year students to gather in smaller groups in large rooms and shift around to at least have some opportunity to meet their classmates. What about the traditions of basic science education? Go back many years. Typically well-attended lectures, there were courses, the departments ruled, there were note services, lots of hours dissecting, tons of information. The tools of the trade were the microscope, the stethoscope, so forth. In clinical science education, there were, as I put it, some intimidating attendings. Pimping was considered totally okay. Everybody caught babies, learned about death. And for anybody who trained at Charity Hospital, we know it was true. See one, do one, teach one. And then on match day, everybody got a spot. Well, where are we moving forward? Okay, so day one of medical school, still pretty awesome day for most people, but very different this year. The white coat ceremony has arrived. Almost all medical schools do some type of white coat ceremony, though this year it's been significantly delayed. What about basic science education? Well, there's no way to learn all the facts first, so we don't even try, which is appropriate. Lectures are recorded, if there are any. They're certainly not well attended. They're not well attended at any medical school. We teach by systems, and many schools now have only one department of medical education. There's no such thing as a note service because there are commercial products and people spend time preparing for step one. The cadavers are dissected, but there are various numbers of hours, all the way down to one school that has 30 hours of dissection total, and we'll see what happens in the future. The overwhelming amounts of information is there, but we don't focus as much on facts. And some of the tools of the trade have pretty much disappeared from medical school. So stethoscopes obviously remain, though they're changing. Microscopes are gone, and students don't buy ophthalmoscopes or otoscopes anymore, though they are occasionally used, obviously in pediatrics. In clinical education, we've got great attendings. Pimping has become polite, maybe a little bit more appropriate. Nowadays, obstetrics is challenging because they're not the way it's done in most schools. It's not as if students are, quote, catching lots of babies, though they do participate in births. Students continue to learn about death as they should. They're hopefully is no more see one, do one, teach one. Those days are gone. And in match day, not everyone gets a spot. So some of the sacred cows have really come and gone and are quite different. So very interestingly, a lot has been written about changes in medical education over time. One of the more interesting papers that was written was a while back by a person named Bloom, not the famous Bloom taxonomy. And as he put it, and I just highlighted some key things in his paper, he said there was just, despite a half century of radical changes in medical practice, we're talking about all the way back into the 1900s, but it could be the previous 50 years, teaching and learning experiences has remained remarkably similar, and he called it a history of reform without change. And at the time, they talked about the humanistic mission being really kind of a screen for the research mission, though that has changed over time. So when you look at what Bloom has done, he really focused on the issue of the traditional curriculum and the challenge of science and clinical faculty trying to do what needs to be done. And again, as he referred to it, the 20th century attempted to make changes. And again, his issue is reform without change. And so the COVID era may create a unique opportunity to truly see reform with change. We've already seen a lot of change. But when you think about this, what are the things that we really need to think differently about? So if you think critically in preclinical education, do students need to come to class? It's very clear that we are educating students and they're not coming to class, and we don't even worry about it because they're all online. We provide opportunities for them. Why are there traditional lectures, and do we need to do the quote traditional lecture? And I refer to that as maybe a 45-minute period of time where the sage on the stage imparts wisdom to the students. We really need to do that? Many schools have shown you don't need to. What is the future of cadavers and cadaver dissection? These are considered holy activities in most medical schools, but how much dissection should we do? So all of these need to be raised, and given our experience this year, we will look at that and see how do students do. How much content expertise does medical education require? At one point, we always went after the smartest person on a topic to teach, but we realized those people may not be the person who teaches the best. A lot of clinical material is now taught by basic science faculty. These are all PhDs, and they're pretty smart people, and there's a lot that they learn extra to be able to teach clinical applications of their content, and they do it very well. So again, raising the question of who needs to teach. I could take it personally and say only a nephrologist can teach acute kidney injury, but the reality is anybody who's really a good internist should be able to teach what a medical student needs to know about acute kidney injury. And we all have to step back a little bit from our parochial views of the world. Exams, do students need to take them all at the same time? What if a student says, I'm ready to take my exam? We now administer them remotely with our own software to monitor. May not be necessary for students to do it all at the same time. And how much time is really necessary in the preclinical education? What if a student finished everything in 1 year? And believe me, we know we have students who could finish everything in 1 year. Could they move on to do their clinical activities at that point? When you look at clinical education, even the didactic side of what, where, when, how we do things, again, similarly, providing resources and giving students an opportunity to demonstrate that they've mastered the material, at least from a didactic perspective. But we also, and I referred to it earlier, the importance of having required clinical activities. So obviously, everybody who goes through OB should be able to participate in a delivery, ideally both a vaginal and a cesarean delivery. And certainly you'd expect anybody going through internal medicine to be able to demonstrate that they can do the necessary cardiovascular exam, be able to perform certain duties that you would not expect somebody to be able to move through internal medicine without demonstrating. And then once we do that, then the idea of how much time people spend becomes very variable. So all of these issues are going to raise new questions in terms of how we approach things. And in general, it raises the question of when are students ready to graduate? And as we proved this year, students really were ready to go a little bit earlier because they didn't even finish all the electives, but they clearly are moving on to what they do. So I am going to finish up with a couple minutes left in case people have any questions. But what I've tried to do is give you a snapshot of what was going on when COVID hit and during the initial period. What are the changes we made? And what are the things that we really need to think about differently, particularly those of us who are in the hospital, seeing patients, making rounds with other learners in groups of people that really can keep us all safe during this period until whenever we come out the other side of it, and knowing that it's going to be a while. So again, I'm going to go ahead and stop, and I will open things up to any questions. I'm going to go ahead and answer one question that I've seen already. The question is, are electives considered required clinical activities, and are electives such as medicine specialties available to students? And the answer is, the LCME has defined that an elective is such because it is elective. So it's not a required activity for graduation. It's an extra depending on what people want to do. Students do have opportunities to experience different subspecialties both during their clerkship and certainly by signing up for subspecialty electives within internal medicine during their fourth year. And in fact, I did have a fourth year student who was with me the last 2 weeks of July for nephrology. So that opportunity is definitely available. But again, it's not required for graduation. And what we want students to do is use their electives, regardless of what specialty they're going into, to prepare themselves for their future career. Typically, we want them to do something that they wouldn't do necessarily during an internship, but use the time in medical school to prepare them. That might be somebody who's planning to do primary care, internal medicine, might spend time doing basic orthopedic activities in terms of some musculoskeletal complaints. So.
Well, it looks like there's no more questions. Kevin, I want to thank you for this fascinating presentation. In challenging times, we all have to work together, and I appreciate you sharing your experiences with all of us. Thank you all for joining, and we'll see you next week.